Hello, and welcome to Hadassah Magazine Presents. I'm your guest host, Libby Barnea, the deputy editor of Hadassah Magazine.
And I'm your other guest host, Leah Finkelstein, senior editor of Hadassah Magazine.
We're thrilled to be talking today with three women who are leaders in reframing the conversation and treatment around menopause. Joining us are Joanna Strober, Lauren Tettenbaum, and Cheryl Kinsberg. More on our panelists in just a minute. Thanks to all of you in the audience for joining us tonight. If this is your first Hadassah Magazine Presents program, a special welcome, and we hope you take the time to learn more about Hadassah and the work it does to heal those in Israel and around the world. In the United States, we of course want to highlight Hadassah's advocacy on matters relating to women's health, including menopause and reproductive rights. If you're not already a member of Hadassah, please consider joining so you can enjoy the magazine, which is free with membership, as well as all the wonderful programming the magazine and the rest of Hadassah provides. And of course, your donations are always welcome and valued. Information on how to donate will be in the chat box, along with links for both membership and donations. We welcome audience questions throughout the conversation. Please be sure to write them in the Q&A. Also, this conversation will be available as a video and audio podcast. You will get a link in the follow-up email in a few days, or you can find it if you search Hadassah Magazine Presents wherever you get your podcast. And now, on to the main event. Here in the United States, around 1.3 million women enter menopause every year, and around 2 million enter perimenopause. Menopause, which is defined by a year without menstruation, occurs on average at age 52. Perimenopause denotes the roughly 5 to 10-year phase immediately preceding menopause, but often this entire transition to a woman's post-reproductive life is referred to as menopause. All these definitions are, of course, familiar to our three esteemed panelists who we would like to introduce now.
Joanna Strober is the co-founder and CEO of MIDI Health, a virtual care platform for women in perimenopause and menopause. Before MIDI, Joanna founded Curbo, the first digital therapeutic for childhood obesity, which she sold to Weight Watchers. Previously, Joanna spent more than 20 years in direct private equity and venture capital. Joanna is the author of the book Getting to 50-50, a primer on how women can succeed at work and at home. She was named to the Forbes 50 over 50 list of top innovators, the CNBC Changemaker 2025, and Time 100 Healthcare Leaders. Lauren Tettenbaum, author of Millennial Menopause, Preparing for Perimenopause, Menopause, and Life's Next Period, is an advocate and therapist who supports millennial and young women through life's transitions. As both a lawyer and a social worker, Lauren specializes in professional and personal identity shifts, including the perinatal period and perimenopause. Lauren is the go-to resource for women seeking counsel, empowerment, and connection. Cheryl Kinsberg is the chief of the Division of Behavioral Medicine at McDonald Women's Hospital, University Hospitals Cleveland Medical Center, and a professor at Case Western Reserve University. Her areas of clinical specialization include female sexual disorders, menopause, pregnancy, and postpartum mood disorders, and psychological aspects of infertility. She is a past president of the Menopause Society and the International Society for the Study of Women's Sexual Health, and she currently serves as the Advocacy Committee Chair for the Menopause Society. Welcome, everyone. And let's start the conversation with just a quick note that, of course, women should always plan individualized discussions with their medical professionals regarding their own care. Let's begin. With menopause suddenly everywhere, from news reports to memes on social media to pop culture, do you think it's fair to say that menopause is having a moment? And if so, what's driving this new visibility for something women have always experienced? Joanna, do you want to start?
Oh,
Joanna, your audio is off.
Yep. There we go. Hi. It's really nice to be here. I got to tell you, I'm not entirely sure what's creating it. I have some theories. I wear this shirt all the time. It says
We love
menopause
the
is
shirt.
hot. And I actually made this up a few years ago when I was trying to convince people that they should care about it. And I was talking on a Zoom call and I'm like, menopause is hot. You guys should care about it. And that was actually how I came up with the topic. Uh, I what I'd like to believe is that younger women are coming into perimenopause and unwilling to accept the status quo. And so they are much louder about wanting to feel better. And so they're looking for answers. They're not willing to just say, okay, I'm willing to not feel good. Instead, they're looking for better answers. And that is what's driving a lot of this. I do believe, some of it is the celebrities, but I actually think a lot of it is just that younger women are saying they deserve better. And I'm really proud of them for that.
Lauren, do you have anything to add to that?
Yes, and we couldn't do what we're doing by demanding more information and resources without the women who came before us. So thank you to everyone here on this call. I think millennials who technically were born between 1981 and 1996 have become accustomed to talking about tough topics, whether it's fertility struggles, the struggles of motherhood, postpartum issues, mental health in general. We share a lot. We grew up with social media, and fortunately, we have had rights that were hard won over the years that we are demanding we maintain and that we can access better healthcare. And so I hope that our generation, my generation of millennials, and all of us continue to demand better for our reproductive health.
Great.
Can I add something?
Of
So
course.
on the practitioner side, menopause is also having a moment. And I love that you called it having a moment because by definition, menopause is actually one moment. It is by definition 12 months after your last menstrual period, or if you have a surgical menopause, it's that moment. And I think it's confusing for women because they say, am I perimenopausal? When am I done with menopause? You're never done with menopause. It is the rest of your life, whether it's at 40, 50, 60. But practitioners are also embracing menopause. We still haven't gone far enough yet, though. We still don't have education in OBGYN training or in primary care. We now have 12,000 members of the Menopause Society. That is up from 2,000 just a few years ago. So practitioners are catching on that millennials and Gen Z X's and baby boomers are demanding better healthcare.
Thank you. Great answers. Thank you. Cheryl, this is something I'm going to direct to you. We would love to get a sense of the latest thinking around hormone therapy, which earned a bit of a bad rap about 20 years ago after an abruptly halted Women's Health Initiative study. So what has changed in the medical understanding of these drugs and how they might be seen as beneficial?
Sure. When you're talking about drugs, you're talking about hormones and hormone therapy. So that's estrogen and a progestogen, or progesterone is the general term. If you have a uterus and you are taking estrogen for menopause symptoms, you will need to take progestin or progestogen in order to protect your uterus and the uterine lining. So those are the old or initial treatments that we were looking at in the Women's Health Initiative, which was stopped in 2002 because of some data that came out that gave the sense that while this study was supposed to look at whether menopause hormone therapy prevented heart disease, that was the goal. It looked like there was an increase in breast cancer risk in the group that was taking both estrogen and progesterone. And it was a particular estrogen and it was a particular progestogen. In the estrogen-only arm, there was no increase. In fact, there was a slight decrease. There was improvement in prevention of colorectal cancer. Certainly, we know it's helpful for osteoporosis. But regardless, the press was all over it. And within minutes, practically, everybody came off their estrogen or their hormone therapy. Physicians were frightened to prescribe it. And it took another 18 years before people then reanalyze that data to show while there is a slight increase in breast cancer in that estrogen progesterone group, it was about 8 breast cancers per 10,000. And so they were promoting the idea that there was a huge risk, but the real risk is very small. And again, in the estrogen only arm, there was no increased risk. So the Menopause Society put out a hormone position statement in 2022, which you can get to if you go to the Menopause Society. It's long and it's complicated, so if you don't want to sort of read the details, it says it is first-line treatment if you are a candidate for hormone therapy, if you have symptoms, okay? Hot flashes, night sweats, joint pain. Well, we'll talk about vaginal dryness in a minute, my favorite topic. And brain fog. There are many symptoms of hot flashes, of menopause that hormone therapy is very helpful for. And the fear of hormones has gone away. Now it has gone in the other direction. Now there's been misinformation that we have data that it prevents breast cancer, that it prevents heart disease, that it prevents dementia. It may, we don't have that data yet. We don't have that data yet. We know that it probably doesn't increase the risks. And let me add one more thing to the Women's Health Initiative. The women in that trial were older. And one of the reasons why the data looked the way it did was that the women coming into this trial were often in their 60s and not at the average age of onset of menopause, which is 51 or 52. So that changed everything. So that is why that misinformation went out there. We now have better data, which is why estrogen the black box label has been removed for both vaginal and systemic estrogens. But we need to be careful. It is helpful. It is good for symptom relief, but it is not necessarily for prevention. It is not a panacea. It is not the fountain of youth. And I'm sure Joanna and Lauren hopefully will second and third.
Yeah.
Thank you, Cheryl. Really a very important topic to discuss. Lauren, you'd mentioned millennials and perimenopause a little bit earlier. And you have said in the past that millennials have a chance to be proactive rather than reactive about midlife health. What does that look like in practice? What do younger women just approaching perimenopause need to be thinking about?
Knowledge is power, and it was my goal through writing my book and through supporting women through my psychotherapy practice and meetings like this, these gatherings like these, to educate women. They often don't even recognize perimenopause symptoms. We know that women tend to feel unlike themselves as they enter the menopause transition, and those emotional symptoms are usually among the first of perimenopause. But we're not taught anything about this, and women can really suffer, and they can really suffer for many years. So, educating yourself, knowing what perimenopause is, knowing what treatment options might be available, knowing how to talk to providers about what's troubling you and how to get access to resources is really important. Knowing yourself, and when anything is new and different, knowing how to speak up about it. Also, lifestyle changes, and of course, the wide range of medical options ranging from hormone therapy to other psychotropic medications. And again, I want to emphasize lifestyle, good sleep, good nutrition, good social connection. Those can't be understated.
Lauren, you mentioned speaking up and advocacy. We wanted to ask about that drive you clearly have to advocate on behalf of other women, and whether you connect that drive to your support for other causes, perhaps Jewish causes?
Yes, I proudly do. Very proud to be here with Hadassah tonight and with this community. It's certainly been an interesting time to be publicly Jewish, to be a Zionist, but I am proud to be. I wear my high necklace in my author photo, and I speak at various JCCs and other community centers. And honestly, being a Jewish woman is so much a part of my identity that I see my role as, if not now, when, right? It's up to me with the education and privilege that I have to speak up on behalf of women everywhere and to continue to have empathy and really operate under the principle of tikkun olam, right? Making the
Yeah,
world a better place.
absolutely. Yep, absolutely.
Thank you. Thank you for that, Lauren. And staying with that Jewish angle for just a minute, for Jewish women approaching menopause, there are actually some specific and special considerations, including the heightened incidence of BRCA mutations in the Ashkenazi Jewish population. Joanna, we understand that there are lots of MIDI clients who might carry the BRCA mutation. Can you speak a little bit about what hormone therapy and medical interventions might mean to women who carry such a mutation?
Yeah, what's actually really important is so we do have the BRCA mutation in our family, and so I've spent a lot of time looking at this. In addition, our chief clinical officer at MIDI, as a woman named Dr. Mindy Goldman, she is one of the pioneers in survivorship care and basically helping women who had cancer to figure out what they can do post menopause and what treatments they can use and what treatments they can't use. And then that interest of hers actually also got her into understanding women who had BRCA, because often they have their ovaries removed, right? And so when they have their ovaries removed, they actually go into early menopause. And a lot of doctors don't give them hormone therapy. And so they go into early menopause and they don't have the right treatments. So we're actually working with cancer doctors all over the country to make sure that when women do have their ovaries removed, they immediately get sent to get hormones so that they don't have to go into immediate early menopause. And in addition, there's actually a lot of research that shows that women who have the BRCA gene can absolutely take hormones. So we've been doing a lot of research on this. We actually are tracking all of our BRCA patients, and we're starting an entire part of our business so that we can make sure those women are well supported.
Really, really important to Jewish women. So, Joanna, there's nothing like the tech sector to disrupt standard modes of doing business, or perhaps standard doctor appointments. What gave you the idea that there was a high-tech solution to increase access to menopause care?
Yeah, so part of it is a high-tech solution, and part of it was actually government changes. So I had a really hard time getting menopause treatment for myself. I live in Palo Alto, California. You would think I would have some well-educated providers here, but I ended up going to a primary care doctor. That primary care doctor told me that I should go on an SSRI for my anxiety. They sent me to a sleep specialist because I wasn't sleeping, and marriage therapy. I was really sent on a terrible wild goose chase. And honestly, in the marriage therapy every week, no one ever brought up vaginal estrogen. I'm looking at Dr. Kingsford about this. Can you imagine? Like every week, they never said, "Oh, have you thought about vaginal estrogen?" And that was for quite a long time of therapy. So I learned how woefully undereducated really the clinical community is on menopause. They don't look at a woman and say, "Oh, let's start with hormones." Instead, they say, "Oh, anxiety, SSRI. Oh, not sleeping, sleep doctor." And so eventually I had to drive an hour. I went to San Francisco. I found this great doctor, and she sat down with me and she gave me 3 simple medications. She gave me estrogen, progesterone, and testosterone. And wow, my whole life changed in a very short period of time. And I was also getting back to what we were saying earlier. I was in perimenopause. I was still having my period. So I wasn't even thinking about menopause because I didn't even know what perimenopause was. So what happened was I very quickly got to feel better, very quickly. And I was very grateful. And then I got pretty angry. And I got pretty angry at the doctors who had given me the wrong care and at the system that made me have to go pay $1,000 to get access to this because I couldn't find any insurance covered care anywhere near where I live. So I was, as you mentioned, I was working at Weight Watchers. I had been doing some research for them on the intersection of menopause and weight. And I had this revelation that basically the menopause the COVID, this was during COVID, the COVID laws were changing. And so for the first time, you could actually use technology to take this great doctor that I was going to and scale her care nationally and get it covered by insurance. And that was just this, I was like, wow, like I can take her information and I can then put hundreds of doctors on a platform and I can use her protocols and expand those protocols out to lots and lots of women. And because the laws had changed, we could get insurance coverage. So it was really a combination of laws changing and technology. So now we have about 500 providers on our platform. We're taking care of over 25,000 women a week. And we are able to scale this really effectively because we have a combination, as I said, of the laws changing and really good technology.
Yep. Looking beyond some of that medical care and maybe looking beyond hormone therapy for a minute, Lauren, what supports do you think are essential for women navigating the menopause transition? From a mental health perspective, what emotional and psychological shifts during perimenopause and menopause do you think women are least prepared for?
Probably the rage and the irritability that I hear a lot about. Midlife is often, just by nature of midlife, a stressful time, and not everything is hormonal or related to perimenopause, certainly. But a lot of women tend to lose their coping mechanisms that they've developed, or they get new anxiety or depressive symptoms. And studies show that up to 70% of women experience an emotional roller coaster. That doesn't mean that they're meeting the criteria for a mood disorder like major depression, but they deserve support if they're not feeling good, if they're not feeling like themselves, if they're snapping at their loved ones and yelling at their children and feeling like they can't be at work anymore because they don't recognize themselves. They deserve support. Women don't need to be suffering to get support. So I think it goes back to knowing yourself, building support systems. If you've had a previous episode of depression, you are at higher risk of another episode during perimenopause. And that might sound scary, but again, knowledge is power. If you know the risks and the risk factors, you can set yourself up for success and you can build a support team with loved ones, with professionals, with various resources like support groups, and it doesn't have to be this doom and gloom time of your life.
Can I ask Joanna, since you got put on estrogen and progesterone and you said, why didn't anybody ask me about vaginal estrogen? I hope they added in vaginal estrogen as well, because I'm going to want to talk about sex. But speaking of BRCA women, we just published a paper on the impact of hormone therapy on women who've had risk-reducing ovarectomy. And the reality is that estrogen, because oftentimes they don't have a uterus, estrogen, they always don't, is not enough for many women when it comes to sexual dysfunction and GSM. And there is a disconnect. We need to teach clinicians that while systemic hormones, estrogen, for example, will help with hot flashes, perimenopausal mood issues, it is often not enough to address vaginal dryness, pain with sexual activity. And what they really need added in, it's not just enough, is a vaginal estrogen or vaginal DHEA or a spermifene. There are many options. And for women who are not able to take hormone therapy, we actually, besides the SSRIs, which often have side effects, or SNRIs, which often have side effects, we now have 2 approved non-hormonal treatments for vasomotor symptoms that can probably also help with sleep, because we didn't talk about insomnia, but that is a huge problem for peri and postmenopausal women, and it's not just due to hot flashes. The loss of estrogen absolutely impacts our sleep cycle, and so many women will have what we call WASO, waking after sleep onset. So it's not about falling asleep. It's not about early morning awakening. It is waking up at 2 or 3, not just because you have to pee and not just because you're having a hot flash. It is an insomnia issue. Anyway, We really don't talk enough about those other options. There's one called Linquet, and there's another one called Veoza. Those are non-hormonal treatments. They work on receptors in the brain that are related to hot flashes. And I just want to throw that out there for women who may not know that those treatments exist. So they should be asking their healthcare professionals about those too.
Cheryl, that's actually a perfect segue for my next question, and the question that many in our audience would are waiting for. You know what's coming. Among your many specialties is menopausal and postmenopausal sexual health. What do you think women should be more aware of, in addition to vaginal dryness and a couple of things that you mentioned, regarding their sexual health in perimenopause, menopause, postmenopause?
All
Either way.
pauses.
Right.
So, Lauren was talking about how millennial women are not afraid to talk about menopause. Everybody is still afraid to talk about sex. No matter what their age, they are still uncomfortable. And so, number one, give yourself permission to accept the fact that you are entitled to a healthy sexual life. Whether you are 40, whether you are 50, whether you are 60, whether you are 80, you are entitled to a healthy sexual life. And so you should be asking your healthcare professional about your sexual concerns. And if they're uncomfortable, because some are, find somebody else who isn't. And to Joanna's point, thanks to the only silver lining for COVID has been telehealth. And so we do have sexual health experts that can provide care. I'm licensed in 42 states. So there are practitioners, if you can't find one in Palo Alto or Cleveland, Ohio, which we do, you can find them, whether it's at MIDI or various places. But I think women should pay attention to the fact that there are four categories of sexual concerns. One is sexual desire. Many women will talk about their loss of desire, their loss of drive at midlife. We know that it is not specific to menopause, right? We have data, and Susan Davis just published on this, that it is not menopause per se that causes what we call hypoactive sexual desire disorder. It is an aging process, but it often is noticeable at midlife. So for many midlife women, they will notice they don't have the appetite for sex the way they used to, or they may have trouble with arousal, which is genital sensation, or they may have trouble reaching orgasm, or with genitourinary syndrome of menopause, which hopefully we're going to put in the chat a nice little diagram of what that is. Without estrogen, the whole urogenital tract starts to become thin, dry. It kind of atrophies a little bit. We've changed the terminology from vulvovaginal atrophy, because who wants to know that they're atrophying, to genitourinary syndrome, because it's not just the vagina, it is also the vulva and is also the urinary tract. So that women may often notice they're having more UTIs or pain with urination. And so it's very important that they can think about using vaginal estrogen. And to Joanna's point about why the heck she was in marriage counseling and nobody talked to her about, pain, it is very easily treated. Now that will take care of the pain, but sometimes women will then develop anxiety if they've had pain. So don't forget cognitive behavioral psychology and CBT, cognitive behavior therapy, can be very helpful to help reduce the impact of hot flashes, to help regain comfort with sexuality again, to address low desire when it's a relationship issue. I always say it's not necessarily the age of people in the relationship, it's the age of the relationship, right? Because after 10, 20, 30 years, you have to work harder to build up passion and excitement and romance, right? And women actually get bored more quickly than men do, because men can rely on testosterone to push their drive, and women need a little bit more, romance and novelty and excitement. Which then brings me to the topic of testosterone. So people want to know, we know vaginal estrogen for GSM. What about desire? So yes, cognitive behavior therapy. Yes, For some women, testosterone, particularly if you are low in your premenopausal, if it's dropped below what your premenopausal levels are, we have no way to measure it. It is not on label. There's no approved testosterone treatment for women. We have a published guideline of how practitioners should use testosterone with women. So please, whoever's out there, no pellets, no pellets, no pellets. We use FDA-approved male gels, and we use about 1/10 of a daily dose for women that would be using for men. It's a little topical gel they can put on the back of their calf. And what we're trying to do for women who respond to testosterone is bring them to their premenopausal levels, right? Not super levels, just what they were in their 30s and their 40s. There's also a drug called ADDY, ADDYI, which after 10 years on the market, finally the FDA approved in postmenopausal women. For some reason, there was this assumption that women were two species, pre and post. This is a non-hormonal treatment, and it is now approved in postmenopausal women. Yay. First and only treatment for postmenopausal women with sexual dysfunction. There's another drug called Vyleesi, which is an injectable that has not yet been studied in postmenopausal women. And there is sildenafil or topical Viagra called Dare to Play that is now available for women with arousal disorders. So just saying, there are treatments out there besides cognitive behavior therapy. Please ask and come to the ISWISH website or the Menopause Society website or go to MIDI and make sure that you ask for help because you certainly deserve it and we can treat sexual concerns.
My understanding is that MIDI is the largest provider in the country of most of these things, which is both good and bad, right? Like women have a really hard time getting access and we prescribe a lot of them. So every one of those medications that she was talking about, we are actively prescribing every day. Quite honestly, along with erotica and vibrators. So it doesn't have to be medication. There are other, we have a lot of other tips and tricks of things that can work. And we have an entire protocol of lots of different things that women can try. So there are a lot of medications, but there are other cognitive behavioral therapy, but other things as well that we recommend.
That's great. That's great. And I know some people are asking questions about names of some of these medicines. I think maybe the easiest thing to do would be for me to tell people to look both at MIDI and maybe at the Menopause Society website would all these, because I don't know that we're going to be able to spell them correctly ourselves if I were to try typing them. So I would say
who comes up with these names anyhow? They're very hard. They're hard to remember.
Well, think about
They are hard.
as add your interest. Add your interest.
It's
So
ADDYI.
ADDYI. Vyleesi
Okay.
is VYLEESI.
And just
Okay.
a reminder, these links are in the chat. These websites are in the chat.
Yes,
So.
yes. And also, Cheryl did mention an image, an explainer image for when you were talking about I'm not gonna remember the name of it, Cheryl. GSM.
GSM, genitourinary syndrome of menopause. Just call it GSM.
Right. So if people are interested in more in like a visual explainer of that, there is a photo in the chat box that everybody can reference.
I just think a picture is worth 1,000 words.
Sure.
Women will say, why does it hurt when I'm having sex now? It didn't used to hurt. Why does it hurt? And that picture's, oh my God, of course, now I know because my vaginal canal is now thin, dry, it's easily damaged. It hurts. And that makes sense to women.
Yep. Cheryl, as a follow-up, I understand that as a clinician and as past president of the Menopause Society, you use what you've called a biopsychosocial approach when you treat patients. Can you explain what the biopsychosocial approach means?
My downfall of big words, right? GSM and biopsychosocial. Really, it's looking at the fact that when we think about sexual concerns, we think about them that there are many factors that can contribute. It could be neurochemical, that is, for example, lack of dopamine, or if you're on an SSRI, so many women will have, and men too, will have sexual side effects of being on an SSRI or an SNRI, right? Either problems with desire, problems with orgasm. So hormones can have an effect, either causing GSM and general health issues. That's the bio part of biopsychosocial. Psychological aspects can contribute, and Lauren was talking about this so eloquently, talking about all of the psychological factors that can contribute to midlife stressors, right? So it could be relationship issues, it could be depression, it could be anxiety, could be having little kids, could be taking care of elderly parents. There are many psychological factors, sociocultural factors, right? Everybody on this webinar is probably more comfortable talking about sex and menopause, and I hope they are now. But there are many people who have religious and cultural factors that contribute to sexual concerns. For example, I see lots of women who have vaginismus, which is the involuntary tightening that makes wanted penetration impossible because they've grown up with such religious, fears that, oh, no, can't touch down there, and certainly wait until marriage if you are going to get married to have penetrative sex. So sociocultural factors, and then interpersonal, the quality of a relationship, right? You could have all the biologic drive, right? But if you don't like your partner, you're not going to want to have sex with that person, right? And so we look at all those factors. It could be one, it could be two, it could be all of them, and they could be combined. So when a woman comes into my office, I ask her, what's going on for her so that I can then plan a treatment that's going to be appropriate for her, because it's not a one size fits all. Some women will benefit from medicine, some women from lifestyle changes, some women from cognitive behavior therapy, some from some combination. But a clinician will figure out which factors are contributing to her symptoms, and then that guides treatment. So it is not a one size fits all, and we have many options. We just need to talk about it.
That's great.
Can I just add, because I'm trying to answer questions in the chat, and you can see from the questions that there is such a range of symptoms and such a range of experiences, and women are hungry for answers, and we deserve those answers. We are not going to answer individual questions today. Every woman is different. Every woman goes through menopause differently. And of course, we can't advise on your personal health history or goals. But I think the point of this conversation is that there is a community, there are resources available, and we've given many, and has such a robust website, for example. There are so many ways to feel better. So if you're not feeling good, please seek out options that you deserve.
Absolutely.
I think the one thing I want to add to that is because this is my third webinar today, and there's so much misinformation out there. And I know that's really hard to navigate. And it's also hard because a lot of the misinformation is coming from your doctors. And so I want to just acknowledge that, because there are lots of doctors that we trust who are not up to date on the most recent information. And so, I've been asked all day long, I've been told I'm too old for hormones. You're not too old for hormones, especially not vaginal estrogen. We put it on 85-year-old ladies because it prevents UTIs. Like, you are most definitely not too old for a lot of these medications. And just because you had stopped having your period doesn't mean you still don't need to be treated for menopause. As Cheryl said earlier, menopause may be a one-day thing, but it goes on for the rest of your life. But I think the really hard thing for me is how many doctors will tell you, go on an SSRI for depression, for example. Okay. SSRIs have a lot of side effects, and they're also addictive. So we see many women come to us and they've been on an SSRI for 5 to 10 years because they were in perimenopause and they were put on one. And then we have to get them off of it in order to even try to see whether there's other things that we can do. I'm not saying all SSRIs are bad, but what I'm saying is, if you're in your 40s and you're feeling the rage that Lauren is talking about, because that is the number one reason people come to us, it is mood disorders. It is rage and anxiety. It's actually bigger than the hot flashes. I think women are willing to deal with the hot flashes. Like, it's okay, I'll have the hot flashes. The things they are having a hard time dealing with are their rage and their mood changes are probably the number one thing that really gets them. And what happens is they go to the primary care doctor and they give them an SSRI instead of giving them the right medication. So don't think you're too old. Do your research. There is really good research out there. You have to talk to a doctor who's really educated, whether it's from the Menopause Society or, and that's a good place to start, or the MIDI website. Like, we do the research. We have a lot of researchers doing all this research. I guess what I'm saying is, like, a lot of you, I've just had all day of people asking me, like, I've been told my mother had cancer, so I can't use hormones. That's just false. There is no reason why, if your mother had cancer, you can't take hormones. Like, there's so many falsehoods out there. And I think we got to figure out how to overcome a lot of these falsehoods so that women, you're getting the right care.
Thank you. One little caveat there. Age does matter with
hormone
therapy.
It does. Absolutely. It does
matter. When
you
say you're not too old, the Menopause Society guidelines would say within 10 years of onset of menopause or by age 60. It doesn't mean that there aren't exceptions.
So we have lots of patients who they get a calcium artery score, and then they are able to take hormones. But there's protocols. There's lots of updated protocols.
I just don't want the misinformation that went out a few months ago that said everybody, because now you talk about the social media, now women in their 70s and 80s are coming in saying, did I miss the boat? Because I was, I went through menopause during the Women's Health Initiative. And so now I see that it's the fountain of youth, and what can I go on? And for the most part, women in, it's an individual in that, over 60, but really be very careful and don't assume that you're never too old to start systemic hormones. You are never too old to start vaginal estrogen. And these other drugs are certainly possible. And SSRIs may be difficult to come off of. They are not technically addictive.
They're difficult to come off of. We are having a lot of issues right now trying to get women off of SSRIs.
But by definition, they're not addictive.
I'm going to jump in with a couple of audience questions, and thank you to Joanna and Lauren. You've been answering some of these, but I want to really make sure that everybody on the webinar is able to hear some of these. And again, some people are writing in with very specific questions, and I don't know that we're in a position to answer very personal questions, but general ones we can certainly try to answer. So. Somebody has a question about connection between gut health and menopause. They feel like their gut digestion has slowed down immensely with perimenopause and menopause. I can't eat many foods now, IBS-like symptoms. So can one of you speak about a correlation between gut health, motility, and menopause?
Women don't get enough fiber. I'll just say fiber. There is definitely a connection.
And it may be more age-related than specific to menopause.
But it's complicated.
Okay. Wait, I'm scrolling back up. Okay, so this is a question I myself have had. Actually, I know many women who've had this question. How do you get accurate results from hormone tests when you get your blood drawn one time? It's a snapshot of you on one day. Since hormone levels change over the course of a month, don't we need readings more frequently? And since everybody's different, how do I know that my normal perimenopause levels were where they should be?
You don't.
Good point. Yes, it is hard to know. It's a snapshot, and by definition, perimenopause are the fluctuations of hormones, which is why you have more symptoms, right? Margaret Mead coined the term postmenopausal zest. Many women, once they are through that transition, can really now sort of shine. So do not assume that menopause means the end of your brilliance, your creativity, your growth. Perimenopause is the harder part. So keep in mind postmenopausal zest. But the question to the hormone testing, if your FSH level is above 30 nanograms per deciliter and it stays consistently, and yes, you should have it tested more than once, but a high FSH, follicular stimulating hormone, that is pretty much a sign of menopause. But I get lots of questions about testosterone, and there is no great accurate testing for testosterone levels in women. It requires a fancy lab, and so you're trying to get a total testosterone, which will give you sort of a snapshot, and even time of day does determine that. And it doesn't tell you whether testosterone will help you. It doesn't tell you whether you have hypoactive sexual desire disorder. And we only use it for sexual desire. We don't have data that it does other things. So again, if people think it's going to, give me the fountain of youth, we have data on desire, and it's an empirical use of testosterone, meaning you can measure it. It won't tell you whether you have a problem, and it won't tell you if it'll help. We use it, we measure to make sure we haven't put you into a really high range, and then we see whether it helps.
Okay. Okay, so it looks like we've temporarily lost Joanna, but I'm sure that she is going to come back in just a minute, and she probably just had.
Right.
Um,
These are all great
yeah,
questions, and I absolutely love, Cheryl, the postmenopausal zest.
yeah,
That's
very
wonderful.
optimistic, isn't
Yeah.
it?
Are we waiting a minute or two for Joanna?
Yeah, but as let's give Joanna just a minute to see if she comes back. But as we do this, I'm going to ask a question. This was about perimenopause. So Lauren, maybe you'll know this, and if not, somebody asked, "Are you familiar with the perimenopausal symptom called internal vibrations?"
I haven't personally heard that,
Mm.
but I will say that anything new and different that can't otherwise be explained, I mean, it's certainly worth talking to your provider about.
Okay. Okay.
Okay.
Okay, there are lots of other,
Yeah.
let's see. Wait. People are asking about weight gain, which is common during menopause. And somebody's wondering if GLP-1, if
Libby,
GLP-1 would
I'm
be.
so glad you asked, and I'm sure Joanna's going to jump in because there's just a recent study showing the combination of hormone therapy and GLP-1 works better in weight loss in peri and postmenopausal women than GLP-1s alone.
Hmm,
Huge
okay.
fan. Yes.
Okay.
We recommend them, we prescribe them, and the combination of hormones and weight loss and GLP-1s is a very effective solution.
Okay.
Although GLP-1s carry their own risks, side effects, and talk about hard to come off of, you can't
Mm.
really. And for many women who just wanted to lose some weight, that extra 10, 20 pounds, unfortunately, once you stop, your hunger tends to come back and your metabolism is affected by it. And many people will note weight gain. It is a game changer, and I am not against them. I just want to make sure there is full disclosure of pros and cons.
Okay.
These are all fantastic questions, and unfortunately, we can't get to all of them. And we've all just you've all of our panelists have discussed information and misinformation, and so we're throwing this out to all of you. If there's one myth about menopause that you would most want to retire, what is it? Lauren, would you like to start?
Yes, so I am 40 and I continue to get looks of astonishment when I say that I wrote a book about menopause. People think, oh my God, menopause, you're so far away from that. And they assume it's an old lady issue. And it's not. Menopause, of course, as we've learned, can start in one's late 30s, early 40s, and that's spontaneous menopause transition. I'm not even talking about surgical or induced menopause. And it is a time in our life that can last for several years with several symptoms. So knowledge is power. The more that we know, it's never too early to get prepared. And I think that women deserve information and access to care and bodily autonomy.
Joanna, the one
Um,
myth.
yeah, I think you don't need to suffer. Don't just suffer. Don't just bear. Don't just grin and bear it. Don't suffer. I'm probably more aggressive than Cheryl in my desire to get women access to things and let them try them and see how they feel. But I believe really strongly that you should try whatever you can that is legal and safe to help you feel better. And you should experiment and be open-minded to different things. And whether it's nutraceuticals or whether it's weight loss medications or whether it's hormones, like be open-minded and realize you don't need to suffer. You can you can feel great, and you should be proactive in trying to do that.
Cheryl.
Well, I'm not going to disagree with the women shouldn't suffer. I think the biggest myth is that it's a natural part of aging and therefore you should learn to live with it. And that is not true. Our hair turns gray, we don't live with that. And we certainly can have many, many treatments that can be helpful. I don't know that I am not wanting women to try things. I just want to make sure they are evidence-based and that it's shared decision making with patients and their practitioners so they know the pros and the cons. And, the Menopause Society will talk about evidence-based medicines. At university hospitals, we've developed a midlife women's health program that has many of the same things that MIDI has in that we have not just primary care and OBGYNs, but just to the point and to Lauren's point about is it being sent for, SSRIs or therapy? If it is a sleep problem, we have sleep medicine. If it is a weight problem, then we have endocrinologists who are obesity specialists. We have rheumatology. We have a whole list of every subspecialty and a practitioner who is interested in midlife women with those problems so that they don't get shunted off to, oh, it must be depression, take an SSRI. They recognize that we're starting with midlife and midlife women, and it's not always just a menopause symptom, but it is about midlife. And we want to make sure that women have healthy lives well into their 80s, 90s, and beyond.
That's a very good note to end on. Thank you, Joanna, Lauren, and Cheryl, for being with us for this important discussion. And if you could, please stay with us just a minute longer. Before we say goodbye, we have a few announcements about upcoming programs. On Thursday, February 12th at 8 p.m., Hadassah Magazine executive editor Lisa Hostein will speak with award-winning author Mary Morris about her recent novel, The Red House. A mystery that toggles between contemporary New Jersey and Mussolini's Italy during World War II, the book explores hidden Jewish identity and history and the lasting impact of trauma. And on March 26th, Lisa Hostein will be in conversation with award-winning novelist Allegra Goodman about her new book, This Is Not About Us. And don't forget, in case you missed any live Hadassah Magazine Present events, you'll be able to get the podcast version and listen while taking a walk, commuting, cooking dinner. Please be sure to share the podcast with your family and friends.
We would like to thank the magazine's digital editor, Ariel Kaplan, who both promoted and produced this event. And we'd like to give a shout out to our partners in the engagement division and the marketing and communications division of Hadassah, who always play an important role in making these events happen. And a huge thank you, of course, to Joanna, Lauren, and Cheryl for taking the time to share their insights and wisdom with us. Thank you.
Thank you.
Thank you. And thank you all for joining us today. I'm sorry that we couldn't answer more of your questions. They were all very important. And we do recommend that you look for the follow-up email that's going to come out next week and have a little more information. And we hope to see you back at our next program, everyone. Good night.
Good night.
Have a good night.